Hello everyone, I'm Dr. Paula Bray, the Acting Director of Research at the Sydney Children's Hospitals Network. And it's my absolute pleasure to welcome you to the first episode of our Advanced Therapeutics Webinar series for 2022. As you know, advanced therapeutics is rapidly evolving and promises to deliver innovative, potentially transformational treatments for children in future years. So today we'll be speaking to the experts about pharmacy considerations for working with advanced therapeutics. But before we get started, I'd like to begin by acknowledging the traditional owners of the lands on which we are all meeting today. This webinar is being hosted from the traditional lands of the Gadigal and Bidjigal people of the Eora Nation in the east and the Barramadigal people of the Darug Nation in the west of Sydney. I'd like to pay my respects to elders past and present and acknowledge the community members, Aboriginal staff, services and organisations who work closely with us to improve the health and well-being of children and young people, their families and communities. So today we are joined by three senior pharmacists at the network who will be sharing their experiences in gene therapy, CAR T-cell therapy and phage therapy. So we welcome Joni Donagher, Kyall Homberg and Tony Lai to this webinar. Following their presentations, our panel will be answering selected questions. So please submit your questions throughout the webinar via the Q&A tab in the Zoom controls. And if you see a question submitted that you'd like to have answered, you can upvote the question by clicking the thumbs up beside it. So now let's begin with Joni, who will kick off this webinar with pharmacy considerations for working with gene therapy. Thank you, Joni.
Thanks, Paula. All right, so let's works. Hi, everybody. So I'm Joni Donagher. I'm a senior pharmacist and I work at the Children's Hospital Westmead. I've been dealing with gene therapies for about 12 to 18 months now. And what I kind of want to cover in my part of the presentation is just what are advanced therapeutics, so we're all on the same page, talk a little bit about kind of pharmacy governance and resourcing and what you kind of need in your institution if you're going to use therapeutics like these. And then talk a little bit about gene therapy, and then I'll hand over to my colleagues for CAR T cells and bacteriophage therapy. So what are advanced therapeutics? So it's a new class of medicines and it's all based on genes, cells and tissues, and they have the potential to treat diseases and injury that currently have very limited treatment options or no cure at all. So they can be classified into four different classes. So we have gene therapy products, which can be in vivo or ex vivo, somatic cell therapy products, tissue engineered products, and bacteriophage or phage therapy products. When we're talking about gene therapy, so it's therapy used to introduce new genetic material into a patient. When we're talking about in vivo, we put the gene into a vector and then that vector is inserted into a patient. And then the gene needs to get into a human cell to have an effect. Ex vivo is gene therapy that kind of happens outside of the person. So we take the cells outside of a patient, we modify them, and then we put them back in. There's also somatic cell therapies, which use stem cell drugs. Now, it's not transplantation. These are actually off-the-shelf products. Not something that pharmacy deals with a huge amount. We also have tissue engineered products, sometimes referred to as regenerative medicine. So that's the kind of practice of combining scaffold cells and biological molecules into functional tissues with the aim of tissue engineering to restore, maintain, or improve damaged tissues or organs. Again, not something that pharmacy deals a lot with. And then the final class would be our phage therapy products, which are viruses that attack bacteria and really useful when we've got highly drug resistant bugs to deal with. So I'm going to start off with some of the boring stuff, but ultimately this is some of the most important stuff for pharmacists to be aware of if you're actually going to use this within your institution. So if we look at how our advanced therapeutics actually regulated, now I'm going to keep the content on here very Australia relevant and talk about some of the products that are registered within Australia, but there are numerous more products that are licensed overseas with the EMA, the FDA and MHRA. So I guess in the same way that pharmacy would handle any other prescription or non-prescription medicine that's TGA registered in terms of storage, documentation, stock management, we need to do the same for some of the advanced therapeutics. Because some of these therapeutics are licensed by the TGA and labeled as medicines. The TGA doesn't yet have a really good definition to what advanced therapeutic products actually are, but everything I'm going to talk about does fall under that umbrella. So some of the medicines that are currently licensed within Australia are things like Zolgensma, which we're using for spinal muscular atrophy, which is in vivo gene therapy, Luxturna for retinal dystrophy, again, an in vivo gene therapy, and then Chimera, which we can use for leukemia, that's a CAR T cell therapy, and that will be ex vivo gene therapy. So these products all have a PI and some are actually handled within pharmacy. Now, what's really important is all of these products also have an Office of the Gene Therapy Regulator license, which deals with GMOs. And this is all regulated from the Australian Department of Health. Having a license from the OGTR, it's applicable to anything that is in a clinical trial, but also with TGA registered products. There are different types of licenses available when you're dealing with these GMOs. So it can be dealings not intended for release, dealings intended for release into the environment, inadvertent dealings, and the type of license will kind of dictate how you handle a product. What's really important is that you understand that you need to actually look at the PI and also the license, because it is quite different in what it covers. So your OGTR license is going to cover things like importing your product, how you transport it, disposing of waste, who's covered to use the product, any notifications and reporting that you need to do when you're actually handling this therapeutic. The license might also be held by the institution or the drug sponsor. So if you're running a clinical trial, the institution might actually hold the OGTR license. If you have a TGA registered product, it might actually be the pharmaceutical company, and the pharmaceutical company would be then responsible to make sure that you are actually complying with all the regulations within the license. So it means that not every hospital or every institution can actually use these products. So we've actually been accredited from some of our sponsors to use some of these products, and they're making sure that we comply with everything that's in the license. Now, for more information on the OGTR, you can actually find everything kind of on their website. And it'll tell you kind of all the regulations that you're going to have in some of the licenses, the different types of facilities you might need, and just goes into kind of a lot more detail on, you know, how to transport, store and dispose of GMOs. And it goes into information as well on things like having an institutional biosafety committee, on what this would actually do and how it would be useful at your hospital. We are aware that not every institution has a biosafety committee. One of the things that the OGTR license A goes into is the type of facilities that are required when we're handling advanced therapeutics. And this is actually really important. So generally, the products that we've been dealing with at the network have been classified as this DNIR type license, so dealings not intended for release. And it's actually meant that we've needed to handle everything within a PC2 facility, which is a type of biosafety cabinet. And it's often you'll use a PC2 for any activity involving material which is likely to aerolize or microorganisms that might be transmissible by the respiratory route. But yeah, if the license says you need this type of facility, then this is actually what you're going to have to work with. I've actually just stolen this Venn diagram from an SHPA talk, but really it outlines quite nicely what the difference between the TGA and the OGTR actually is. So although both of these, your license and your PI, it's all about patient safety, the OGTR is really going to look more at environmental safety, and the TGA is going to more look at the quality and efficacy of your medication. So really quite different things. Now, these therapeutics are currently listed as some of the most expensive therapies in the world. So finance need to be involved in any conversation if your institution wants to use them. What pharmacy needs to get the payments processed, and the funding is probably going to be outside any current ABF caps. As of March this year, there's currently no advanced therapeutics listed on the PBS. That might change, so I would just say watch that space. We have accessed quite a lot of this on compassionate grounds and through clinical trials. Now, I'm specifically going to mention Luxturna under financial governance, just because it has kind of a bit of a funny funding model, which we're kind of doing through the Medical Services Advisory Committee, where it's 50-50 kind of state and Commonwealth agreement. And it looks at funding the entire treatment and not just the therapeutic acquisition of the drug. So I've kind of put a comment up there, the requirements might be variable depending on where you are in Australia. And like I said, this particular agreement is it's got state and Commonwealth components. So if you want to use something like this, it's probably something, depending on where you are, that you might need to look into a little bit further. What does your hospital actually need if you want to use these type of therapeutics? Really what you need is trained pharmacists. So within pharmacy, you need a pharmacist who can take receipt and storage of these products, because a lot of them are being stored at -80. You need somebody who can prepare and manufacture a product within PC2 conditions. Somebody who knows how to transport the product, and that might be as per your OGTR license. A lot of these products are still in clinical trials, so you might need people with clinical trials training, and then someone to monitor fridges and freezers, which is the sort of thing you'd have for kind of normal hospital accreditation anyway. Medicines and therapeutics committees will need to be involved. It's very unlikely that these drugs are going to be on your formulary, and you are going to need the right level of expertise on your drug committee to be able to assess any applications. Access to an institutional biosafety committee. Now, it's not an absolute requirement, but it can be really, really useful, and would definitely recommend it. So we have a biosafety committee. It's primarily made up of scientists and not clinicians, but they do help with things like risk assessment, reporting to the OGTR, and things like biosafety training. Electronic prescribing systems. So our gene therapies are often dosed in viral genomes, not things like milligrams. So you need to make sure you actually have things built into your system that you can safely prescribe and administer these therapies. And then having policies and procedures for staff at your institution, and at a minimum, we'd say, handling of dry ice, because most of the therapies that we've had have come in on dry ice. We would recommend that you do have policies around how to actually prepare advanced therapeutics, working within a biological safety cabinet, waste management, because there is a lot of information about how you need to manage biological waste, especially again from the OGTR, how you transport it, how staff are going to administer it, and you might actually want specific policies for specific types of therapeutics that the nurses and doctors can actually work with if you're giving this on the ward. Biosafety training. Now, that will be a requirement of the OGTR license if you're going to use these therapeutics. And it's actually up to the individual institution to have appropriate training in place. So it normally includes a number of different aspects, and it's really, how would you deal with a biological spill? What kind of chemicals might you need? if you're handling biologicals, how you handle it therapeutically, what do you do with the waste, information regarding like a PC2 facility, who are the IBC, how would you contact them, and what do they actually do. So at our institution, we actually accredit people and give them a certificate once they've done their biosafety training to show that they are competent to handle these type of therapeutics. All right, so very quickly, I'm just going to talk about the clinical pharmacist a little bit and kind of our experience of using gene therapy on the Kids Network. So gene therapy, we have, like I said, in vivo and ex vivo. So gene therapy, it's biological medicine, consists of recombinant nucleic acid. It's housed within some kind of a vector and then delivered to the patient in vivo or ex vivo. Like I said, in vivo before is a gene and a vector that is inserted into a patient, needs to get into a cell to have its effect. And you can either do that systemically, or you can actually inject locally, depending on what therapeutic you're using. And then we have ex vivo as well. So cells are removed from the patient, modified in some way, and then returned to the patient. Now, for gene therapies to work, the genetic material has to be transported into your target cells using a vector. And the vector is just a delivery vehicle for that modified genetic material. So there's two main types. There's viral vectors and there are non-viral vectors. Now, you choose one of the other for kind of, I guess, different reasons, because they both sort of have different properties. It might be related to the size of the gene that you're trying to introduce. Viral vectors can only hold so much genetic material. It might be because of what cell line you're trying to get your genetic material into, or whether or not you need the genetic material to integrate into the chromosome or not. We're mostly using viral vectors and kind of the registered products that I've mentioned use viral vectors just because they're a much more efficient system for getting that genetic material in. However, there are risks for patients and staff that you need to be aware of because we are using viral vectors. So although a viral vector and a virus are not the same thing, your body will still recognize certain antigens and components of that viral vector, and the patient will get an immune response. We do worry about, at the moment, kind of a potential likelihood of transmission to others, because at the moment we don't actually know how problematic it is if you're exposed to some of these vectors, and patients will actually shed them. So if you give something systemically, we do recommend I guess, kind of careful handling of bodily fluids for about 30 days after you received the therapy. And some of the other hazards as well, like depending on the type of viral vector that you actually use, like if you use something like a lentivirus, which can cause genetic integration, you know, are we likely to get any random integration when we're using that type of a vector? So there's still a lot of unknowns when we're using some of these therapies. So like I had said before, you know, you do need pharmacists who know what they're doing with gene therapy if you're going to start using these products. So your clinical pharmacist, so outside of, you know, knowing about governance and actually sending somebody in to manufacture or prepare these products in a PC2, you will need people that triage the patient in the same way they do with any other medicine. You know, make sure that they've actually got drug committee approvals, verify and dispense any prescriptions. Check the medical records, you know, to make sure that these patients have been appropriately screened. Do they have any vector antibodies? So like I said, a virus and a viral vector, not the same thing, but because there are certain viral properties, your body can create antibodies against the vector. So if you have been kind of exposed to this type of virus before and you have antibodies and you go to inject this drug, your immune system might recognize that vector and destroy it really quickly. So that's something we need to look for. And we also just need to look at baseline blood tests, because we will get an immune reaction, and there are some, depending on the therapeutic in question, some kind of specific bloods that we need to look out for different therapeutics. You want your pharmacist to review your patient's medication history, look for any interactions. Most commonly, you're going to be thinking about steroid use and vaccine administration, because most of these patients are going to be on steroids because the viral vectors will cause an immune reaction of some description. You'll need pharmacists who know about, dispensing any of these medications before and after gene therapy, and what's appropriate and what's not, and people to provide medication counseling. And then, like I said, there will be pharmacists well involved in manufacturing preparation. And they're not actually as scary looking as they sound. So this is Zolgensma, which is an in vivo viral vector gene therapy, and they look like any other therapeutic. So this is just an infusion that we'd normally give over an hour, made up in a PC2. All right. So what are we doing across the Sydney Children's Hospital network with gene therapy? So I'm just going to mention two products which are Australian registered products that we actually have experience with and that we've been using. So I'll start off with Luxturna, which is, again, in vivo gene therapy. This one's used for retinal dystrophy. So far, we've treated 4 patients since 2020. We're actually going to have another one this week. But all patients have said that they've had significant improvements in vision from this therapy. And this is just some stuff that I've actually pulled from ABC News Australia, because I really liked some of the statements that the patients had actually made, and kind of shows what this therapy can actually do. So because some of these retinal dystrophies can actually cause blindness and vision loss, and these patients are actually saying, I saw my first star, his night vision had improved, so it is self-confidence. It made me feel great. I can see stuff. I don't have to trip on a bunch of stuff. I'm able to walk at night, and I'm able to go out with friends at night. So it's really exciting what we can actually do with some of these therapies. The other one that we've done a lot more with is Zolgensma. So Zolgensma is gene therapy treatment for spinal muscular atrophy. It has an AAV9 viral vector, and it's used to increase the amount of survival motor neuron protein produced in the body. It's a single one-off treatment given systemically, usually over about 60 minutes. Anybody who knows anything about SMA knows it's a really horrible genetic condition, causes muscle weakness and atrophy. It affects a child's ability to crawl, walk, sit, control head movements. Some of these kids don't even make it to 6 months if they're left untreated. So what have we actually done on the network? So one of our neurologists has actually been really instrumental in setting up a newborn screening program for SMA and children in New South Wales and the ACT. Newborn screening is critical for early diagnosis and treatment of infants prior to them getting any neurodegeneration. And we know from the data, that the earlier a patient is treated, the better the outcomes, because SMA has an extremely high morbidity and mortality if left untreated. Other states in Australia, I think, are still in the process of setting up some of these testing programs as well. So what have we done so far? So we've had 7 children on clinical trials, and we've had another 22 children treated through managed access programs. I'm going to briefly talk about this paper, which was published, I think, just last month. And this actually describes our experience of using Zolgensma across the network. And I'd recommend this to anyone who is considering using this product in their institution, because this paper aims to provide a greater understanding of the tolerability, safety, and clinical outcomes of Zolgensma in real world practice in quite a broad population of infants with SMA. It is a prospective cohort study of children with SMA treated with Zolgensma across the Kids network from August 2019 until November 2021. It looks at a lot of safety and efficacy outcomes. And what's also really useful is it actually describes the implementation of a model of care for Zolgensma administration in health practice. So some of the results that we've actually had from this here, looking at 21 patients, is patients that actually started to attain at least one motor developmental milestone. And these are kids that normally wouldn't be able to crawl or even sit up without support. We had 75% of kids here, starting to sit without support, walking without assistance. We've had infants who actually attain milestones like hands and knees crawling at data cutoff, and these things would have been thought kind of almost impossible before treatments like Zolgensma. So it's quite exciting stuff. And the last thing I would just wanted to touch on is some of the challenges and things we've actually learned from using Zolgensma, and things that would be really useful for people in other institutions. So again, from the same paper, where they talked about, what you'd sort of do in your institution, there's a lot of mention in here of, making sure that you do have facilities in place, to do antibody testing, to get supply, because a lot of this stuff is coming from overseas. We actually don't hold a lot of gene therapy within Australia because we don't have the manufacturing capabilities at the moment for it. So we're getting it sort of on demand when we need it. They talk about, having proper waste management in place, but also the workforce support that you would require if you're going to administer any gene therapies. Do you have trained CNCs, coordinated treatment pathways, how you translate research into clinical practice, and having dedicated pharmacy services. All right, so that is everything that I wanted to talk about. I'm now going to hand over to Kyall to talk about CAR T-cell therapy.
Hello, everyone. Thank you for that, Joni. That was a great presentation. So I'm going to be talking about CAR T-cell, and I'm the Transplant and Cellular Therapies Pharmacist at Sydney Children's Hospital. And I'm just going to cover some aspects of CAR T-cell and my role as the pharmacist. I'll just start off with some acknowledgements. Thank you for the Advanced Therapeutics team for inviting me to speak. Also like to acknowledge my wonderful oncology pharmacy team at SCH, and then the medical team, Professor Tracy O'Brien, Dr. Richard Mitchell, Dr. Karen McCleary, and Dr. Adam Nelson, and then the wider transplant and cellular therapies team in the KCC and the wider hospital staff. It's a really fantastic collaborative effort in order to deliver this complex treatment. So just kicking off a little about CAR T, as we obviously have a varied audience on the webinar. So CAR stands for Chimeric Antigen Receptor, and the T stands for T cells. So back in 2014, I began to hear about this amazing technology capable of weaponizing the body's own immune system against cancer cells in order to cure acute lymphoblastic leukemia patients. And it's just been an amazing journey this technology has undertaken over the past few years in Australia, with the TGA approving commercial tisagenlecleucel, or Kymriah, which is what I'll call it from now on. It's a bit of a mouthful, in 2017, and the approval in 2020 of the Sydney Children's Hospital as a site to deliver this commercial Kymriah, and our first patient receiving their infusion. So CAR T cells are an example of a genetically modified cellular therapy, as Joni mentioned before, where gene transfer technology is used to express chimeric antigen receptors onto T cells. So in our case, CD19 is the target antigen for Kymriah, which is expressed by B cells in our pediatric acute lymphoblastic leukemia patients. So the T cells that we use to make Kymriah CAR T cells are actually the patient's own cells, or autologous cells. And then in simplified terms, the CAR T binds to the CD19 expressing B cells and then causes them to die. So this treatment is currently for patients up to 25 years of age with B cell precursor ALL, but it must be refractory in relapse post-transplant or in second or later relapse. What this really means is that our CAR T cell patients are incredibly complex. They've been through multiple therapies, sometimes including a bone marrow transplant. So they really require the highest level of pharmaceutical care and monitoring and support, and the entire multidisciplinary team to take them through this CAR T cell journey. So the journey begins with a patient being referred to our transplant and cellular therapies team here at Sydney Children's Hospital. Seen by our team, and their eligibility for CAR T is assessed and their clinical condition. And then if eligible for CAR T, consented for a leukapheresis where a VAS cath may be inserted. And then they undergo an apheresis procedure. And the patient's T cells are obtained, cryopreserved, and then shipped to a manufacturing facility where the CAR T is produced. So there are now 2 sites where we can access Kymriah, which is Cellular Therapies in Melbourne, or then the Novartis manufacturing facilities, which are in the US. In these manufacturing facilities, a lentivirus vector delivers the CAR T construct into the autologous T cells, and then those cells are expanded and cryopreserved and then shipped back to us, and then delivered to the patient in an inpatient setting. I thought I'd just quickly touch on some of the results that Kymriah has been delivering around the world. So this is a Pasquini et al. Blood paper, which I'll reference through the talk, but basically an analysis of the largest set of safety and efficacy data so far for Kymriah. And we're showing remission, event-free survival, and overall survival at 1 year here. And obviously some very impressive numbers considering how unwell some of the patients can be when they come to us. And the fact that we wouldn't have been able to offer treatment in many of these patients only a few years ago. So as Joni was talking about before, in vivo and ex vivo gene therapy, CAR T cells are ex vivo and are actually classified as biological. So they're a class 4 biological and stored and handled in the laboratory at SCH. So the TGA has the Australian regulatory guidelines for biologicals, which talk about handling and supply. And so in order to maintain product viability, transport must obviously be carefully temperature monitored, and the Kymriah arrives cryopreserved from the facilities. And our wonderful cell lab team are the experts in cellular therapy handling, and they safely keep the Kymriah until the patient has been prepared for the infusion. So unfortunately, our highly pre-treated patients will once again need to receive some more chemotherapy, and this is as part of lymphodepletion prior to the CAR T cell infusion. So we use a standardized fludarabine cyclophosphamide regimen, which is as per the Novartis Bianca Kymriah study protocol. This conditioning makes room for the newly infused CAR T cells, and it really just provides the best environment for them to expand and function. And this leads to improved persistence in the body and then leading to a better clinical outcome. There's a lot of supportive cares that go along with this chemotherapy regimen. So fluids and mesna for cyclophosphamide. We use seizure prophylaxis with Keppra or levetiracetam. Patients will probably require fungal and PJP prophylaxis and potentially tumor lysis syndrome prophylaxis, depending on their disease state. We need to avoid corticosteroids in conditioning, so we don't use those for pre-medications at all. We usually try and stop any steroids that are the patient may be on 5 days before treatment begins, and we also avoid them post-infusion. They do have an effect on the CAR T cell function and expansion. We also do not give growth factors such as GCSF, especially in the 3 weeks post-infusion, as they can increase side effects, which I'll talk about in a little bit. So we infuse the CAR T cells 2 days, generally after the end of the lymphodepletion. And 2 very important points is the lymphodepletion does not go ahead until the product has been secured in the lab. And the other requirement for starting conditioning is confirmation of the availability of tocilizumab, which I'll touch on in the complications section. So complications of CAR T, I'll just cover two of the main common complications that we do see with our CAR T cell patients. Cytokine release syndrome, or CRS, is a common complication of CAR T cell therapy, especially in ALL population. So this is why we deliver the treatment as an inpatient. And because CRS can present with a variety of symptoms, and some may be mild, but some can also be severe and life-threatening. So we need to be able to support our patients through this. T-cell mediated immune activation leads to the massive release of cytokines. Interleukin-6, interleukin-10, and interferon gamma are the core cytokines. We find those elevated in patients with CRS. The first sign we usually notice with our patients developing CRS is a fever. This generally precedes the development of the CRS by around a day. Day 6, day 7 is around the time that you may expect CRS most likely to develop. We use the American Society of Transplant and Cellular Therapies grading guidelines to grade the CRS, which appropriately guides our treatment. You're looking at fever, hypotension, tachycardia, and hypoxia. With the Pasquini study, they showed the rate of any grade of CRS around 54%. So as we said, quite common. The other unfortunate part of CRS is a lot of the CRS symptoms also can look like infection, and our patients have obviously been through a lot of treatment and also gone through some more lymphodepletion. So we need to be careful to exclude infection as well. This is just a flow chart from a consensus guidelines. So a number of professional bodies utilized the ASTCT grading and then made a suggested management algorithm. So we have our own pre-existing guidelines, and then we make necessary updates as we learn more about how to deal with CRS and CAR T cell toxicities. So the management of CRS. So depending on the symptoms, we, as I said, start with a clinical review and a septic workup, and we can add in some supportive fluids and oxygen if required. Interleukin-6, as I mentioned before, shown to be an important cytokine in CRS. And so if we effectively inhibit interleukin-6, we can actually switch off this cytokine cascade that may be occurring, and it actually effectively manages CRS. And it also doesn't affect the CAR T cell function, which is super important. The treatment that we currently utilize is tocilizumab, which is, some of you may know, is a monoclonal antibody that inhibits interleukin-6. And we use doses of tocilizumab can be repeated up to every 8 hours for up to 3 doses in a 24-hour period, or even up to 4 doses per episode of CRS. Some of you also may know tocilizumab experienced a worldwide shortage recently, as of last year, due to its utilization in severe COVID-affected patients, which presented a unique challenge for our facility in making sure that we had a sufficient stock of tocilizumab to provide safe infusions of CAR Ts or Kymriah to our patients. And CRS it can be particularly severe if you are not able to inhibit interleukin-6. We also may, if tocilizumab isn't effective in treating the CRS, you can add corticosteroids at low doses and for a short period, but we try to avoid corticosteroids due to their function of inhibiting the CAR T cell and its function. The second complication of CAR T cell that you need to be aware of is the immune effector cell associated neurotoxicity syndrome. So ICANS is a pathological process involving the CNS following CAR T cell therapy, and can be progressive and includes a wide range of symptoms. You'll get headache, short-term memory loss, altered mental status, and then it can go into seizures, encephalopathy, and cerebral edema. So it can be very severe. So we really need to take baseline neurological assessments in order to detect the early signs of ICANS, and then we can manage it appropriately. It commonly occurs concurrently with CRS, so you'll get this usually CRS with ICANS around the day 7 mark, but we also you can actually get like a delayed ICANS that is without CRS that can happen up to months post the immune effector cell infusion. So just with these 2 toxicities or complications, I just did want to point out that with appropriate management, CRS and ICANS are actually really reversible, and our patients make good recoveries from these complications in general. From the same guidelines, this is the flowchart for the ICANS treatment. You'll notice the ICE and the CAPD score in the grading. This is for over 12s and under 12s. Obviously, it's difficult to do neurological assessments for different age groups, so there is different tools for those different ages. So we already have the patient on prophylactic levetiracetam for seizures that may develop as part of ICANS. And we need to get neurology involved with seizures and also an ICU consultation for management of symptoms. If the patient has an ICANS grading of 2 or above, it's most likely they'll be making a trip to the ICU just to make sure that we can appropriately manage their symptoms. With isolated ICANS or ICANS with cytokine release syndrome, non-responsive to tocilizumab, we may again use a short course of corticosteroids to resolve symptoms below a grade 1 grading. But yeah, usually tocilizumab, if given appropriately, and then supportive cares, they make a good recovery without the use of corticosteroids. So I'll just talk a little bit about the long-term effects. So with the CAR T cell, B cell aplasia is a on-target off-tumor effect that you would get. So it's a marker of CAR T persistence. So it's something we want to be occurring. However, obviously we get hypergammaglobulinemia, and patients will likely need immunoglobulin replacements to mitigate their risk of infection. We're giving prophylactic antimicrobials, as I mentioned, so PGP and some fungal prophylaxis, and we usually try and avoid live vaccines until immune recovery has taken effect. I guess the other part of CAR T cells is a little bit of an unknown in that the first CAR T cell was only delivered 10 years ago to a patient. So we sort of don't really know like the longer term effects. So that's why it's really important we're taking lots of data points for all of these patients that receive these CARs, and long-term follow-up will obviously be very important as well. So a little bit about the requirements and accreditation for delivering this therapy. So as Joni mentioned, these are incredibly expensive medications or treatments. So Kymriah itself costs $500,000. So as you would imagine, there's those increased requirements. So we need to undergo significant accreditation and credentialing in order to offer CAR T cell therapy at Sydney Children's Hospital. So our centre is Immune Effector Cell accredited with FACT, which stands for Foundation for the Accreditation of Cellular Therapy, funnily enough. And further to that, with the specific Kymriah product, Novartis, the sponsor, needed to give us approval as a site to deliver this therapy. So in a practical sense, that says over 150 staff are required to be educated on a regular basis, and continual quality and assurance needs to be maintained. Ongoing education requirement for these staff and continual quality improvement is managed through rigorous internal processes. And we have the program's quality manager, Dr. Karen McCleary, and her team who take on this important work. So the pharmacist role in CAR T. So as I've alluded throughout this journey of CAR T, our patients are incredibly complex. They require a high level of clinical pharmacy input throughout the CAR T journey and as part of the multidisciplinary team. So we can be involved in bridging chemotherapy. Patients don't necessarily need to be in remission before receiving a CAR T, but there does need to be some semblance of control of the disease before we give the CAR T, as there is an increased risk of CRS with out of control disease, really. We need to do the conditioning protocol. So it's a standardized, validated protocol. It has a pro forma where we input all the data and the numbers, and then we need to check and verify these dosings are correct, the accuracy of the protocol, and then we give the pharmacy sign-off, verifying and checking the pre-built CAR T-cell conditioning power plan in the EMADS, charting the protocol with the fellow, verifying, ordering and releasing the chemotherapy, and then providing the supportive cares that go along with this conditioning protocol. And so these are complex patients. They have pre-existing conditions. They've had a lot of treatment. Their kidney function may be off, their hepatic function, may have cardiac or lung toxicities. And so we need to have a very accurate medication history with including allergies, and then we're cross-checking this conditioning and supportive cares with current medications. Another very important role for the pharmacist is the toxicity management. So it's talking about CRS and ICANS can be life-threatening, and we need to have a rigorous procedure for the tocilizumab dispensing and usage management. And that part of that is the writing of standard operating procedures that pharmacists assist with, and interpreting guidelines and protocols to write practical dosing guidelines and administration guidelines for tocilizumab. Big part of accreditation as well is the preparation of these SOPs and the required documents and guidelines, and meeting with accreditors. And then education is a large part of this work that we do as well. So nursing staff regarding administration of the tocilizumab for CRS ICANS, including some side effects that tocilizumab unfortunately has side effects of its own and can cause infusion reactions. So we do give pre-medications for that as well. And then also to other pharmacy staff, there's essential credentialing and training of pharmacy staff in CAR T procedures, and essential competencies involved need to be maintained by the pharmacy staff. And so then just coming to the end of the presentation, we are talking about Kymriah. That's one specific CAR T product. But there's actually currently hundreds of CAR T clinical trials going on all over the world. And so I've just put up some interesting things that are kind of currently happening that we can look forward to in the future. A potential for a combined CD19, CD22 CAR. So there is a risk of CD19 negative relapse with Kymriah. So they're looking at whether a combined CD19, CD22 CAR can reduce this antigen escape that can occur. We're actually, hopefully in the next 6 months or so, having this anti-GD2 CAR T cell for diffuse pontine glioma. And that's a phase 1 trial that's going to begin at SCH, which it's a really exciting therapy. And then another part of what we're looking at the moment is how to maintain persistence of the CAR. So we want that CAR to be hanging around in the body for 12 months would be ideal usually. And if we lose B-cell aplasia before 6 months, that's a really poor predictor of results. So persistence of the CAR is something that we're trying to improve, and then we're looking at checkpoint inhibitors like pembrolizumab, which does have some promising data to say that it appears to increase the expansion and persistence of the CAR. And I would just like to say, this brings me to the end of the presentation. There is a great talk by Professor Tracy O'Brien, which was in the Advanced Therapeutics webinar from last year. So yeah, if you're interested in this subject, I definitely say that you should have a listen to that talk as well. But thank you very much. And I'm just going to hand over now to Tony.
Great, thanks, Kyall. So I've been invited here to speak. Thank you for the opportunity to speak about phage therapy. So getting straight into it, firstly, I want to really just acknowledge And people on the slide here who might consider really the rock stars of phage treatment on the phage circuit. So we've got John Ardell, Armene, Alex, and Becca Dedrick, who's a scientist from University of Pittsburgh who's been collaborating with us a lot in procuring and making the phages, and Peter Barclay really for the opportunity to be involved in this type of treatment. Just a quick overview of what I'll be talking about. I'll go through why I guess everyone here why everyone is indulging with their time in their busy day. It's important to know about phages, go through a patient case, an introduction on phage treatment and the lessons learned specifically from a pharmacist's perspective. So why is it important for pharmacists and scientists and clinicians in this group to know about phages? Dame Sally Davies is the previous Chief Medical Officer of England, and she put it quite well that the drugs simply don't work. And the drug she's referring to is antimicrobials. And the global threat she's referring to is antimicrobial resistance, which is where the drugs that don't work are antibiotics, antivirals, and antifungals. Microorganisms are developing resistance to these therapies, thereby becoming less effective. And there's quite a few examples of multi-drug resistant organisms in clinical practice, MRSA, ESBL, CREs, and multi-drug resistant TB. And the World Health Organization has really ranked it as one of the top 10 threats in our healthcare, and it bears significant mortality, even more so than cancer, despite the stark differences in funding and research. But not only is it a global problem, it's a national problem in Australia. So this is, sorry for the really busy slide, but basically this is surveillance data showing the increasing rates of resistance to E. coli, which is a common etiology of urinary tract infections, urosepsis. So this is in blood culture showing that with the different types of antibiotics on the x-axis, there's increasing trends of antimicrobial resistance longitudinally. And it's also a local problem here at Westmead Children's Hospital. One of my close colleagues here and friend, Indy Senadura, has done this nice modeling of antimicrobial resistance of E. coli to ceftriaxone, which is a commonly used third-gen cephalosporin for UTIs and pneumonias. And basically what he's shown that it is a concern and is a concern as the years go on. So there's a lot of strategies described by the federal government implementing funding and peak bodies to be involved in attacking AMR, but it's a problem right here, right now. And this is what we see in clinical practice. We'll be getting these antibiograms of very resistant organisms, and we're stuck with therapeutic options. And clinicians may resort to last-line antibiotics like cefiderocol, which is not even TGA approved yet, it's FDA approved. But quickly after its release into market, there's been descriptions of antimicrobial resistance after 21 days of treatment in this case report published in CID. So that brings me on to our first phage patient case, where we had to deal with a patient at the bedside with a very drug-resistant Pseudomonas aeruginosa. So this was a 7-year-old girl who had a motor vehicle accident in India and had orthopedic surgery there, and then came to Sydney and was followed up at our outpatient oncology clinics with an oozing wound, and we grew this. So we grew a very resistant Pseudomonas aeruginosa. So for the non-clinicians in the audience, you got R's, which mean it's resistant to that antibiotic on the left column, and S is susceptible. So there's a lack of options. And looking at the extended susceptibilities, it was really quite resistant even to all the the sexier new antibiotics that haven't even been released here in Australia. And this patient subsequently had multiple washouts in theatre and was giving really long-term hospital and home treatment antibiotics with aztreonam and colistin. So we were stuck with a few management options for this patient, whether or not do we continue antibiotics with a low chance of cure, and descriptions of AMR if we still use it for long term, or we consider amputation, or we consider bacteriophages, which is what John Ardell was doing, interestingly, at Westmead Adults at the time. He was involved in a interventional trial, which I'll go through a bit later. So then we got together, and Amine and John went through the governance required and the procurement of the targeted phage, and we were able to get the phage from Adaptive Phage Therapeutics at the time. This patient was readmitted subsequently with a fever, decreased activity, and was unable to weight bear due to the pain. And the plan for this admission was to give a combination of phage treatment with aztreonam and colistin for 14 days as a 30-minute infusion. And this is a really busy diagram or graph, but this is really from Amine's case report. What I do want to the audience to take out of this slide is that we've got days of therapy on the x-axis. The grey arrows are the doses of phages. The bigger arrows mean there are two doses a day versus 1 dose a day in the smaller arrows. And what I really want you to appreciate in this graph is the purple line, the Pseudomonas aeruginosa genome copies. So you can see that there's high peaks, day 4, day 13, and then the blue line, which is the genome copies of the phage that we gave to this patient. And one can see that there's a dramatic drop in Pseudomonas quantitative copies after there is a peak of phage copies. And the take home of this slide is that this really portrays a predator-prey relationship, which is described in basic biology textbooks, where there's more prey around, the predator thrives, and when there's less prey around, it declines, like a rabbit or fox, for example. So we monitored this patient, and there wasn't any significant side effects, mild transaminitis, but most importantly, everything was fine at the time of discharge after 2 weeks of treatment. In terms of clinical outcomes, here's the baseline of the treatment pre-phages, unable to weight bear with terrible pain. And you can see with the MRI, it's all lit up with inflammation and signs of infection. But as we progress to antibiotics with adjunctive therapy of phages, we have a significant improvement, and it was a successful case of avoiding an amputation in this patient, which is significant for a 7-year-old in terms of quality of life. So moving on to just a brief introduction of phages, there's this beautiful narrative review done by Alex and John and co. So here's what a phage looks like under electron microscope. And it's one of the most abundant life forms on Earth. It's described as being ubiquitous in nature, so it's found everywhere. But it's not a new discovery. It was discovered back in 1919 with over 100 successful cases at the time. But then Fleming discovered antibiotics, and antibiotics took all the spotlight in terms of first-line treatment for antibiotics, improved mortality significantly. But now in 2010 or post-2010, we're seeing a resurgence in phages. But looking back at the 2020 literature, the 1919 literature, it was really old, poorly documented, quite a lot of issues experimentally, and it was really limited to the Eastern Bloc, where the rest of the Western world were using antibiotics. So phages, bacteriophages, are viruses that naturally infect and kill bacteria. It hasn't been described to infect or kill fungi. viruses or parasites. And there was a lot of key differences between phages and antibiotics. Main being that it will cover both antibiotic sensitive and resistant bacteria, and it has less of an impact on AMR. And thirdly, it is able to penetrate and kill bacteria in biofilms. So biofilms is like a clever way where bacteria create a bunker for themselves of dead material that make it difficult for antibiotics to penetrate and cause their bactericidal activity. And they're described in prosthetic infections in metal or plasticware and lines. So that's where phages have their special utility in penetrating those type of infections. Alex has done this beautiful life cycle of a phage, where basically this phage attaches to the cell, injects its genetic material, and then it's replicated within the cell and lyses and releases the virus, thereby spreading and populating more cells. And then there's another pathway, the lysogenic pathway, where the genetic material gets integrated into the host cell DNA. Host cell replicates, and then a stressor is applied. So that's what that lightning bolt is in D. And then that's when it stimulates more of the developing the viral particles in the cell and releases, thereby spreading the phage to attach to more target host cells. Here's a nice little picture of what that looks like. So just going, next few slides will be just going through the FAQs of phages I get most commonly. And the first obvious question is, do they work? So looking at the post-2005 publications, there's quite a lot of descriptions of its use in over 1,000 patients, ranging from respiratory tract infections to sepsis in multiple routes, from oral, nebulized, topical, intravenous, and intrarectal. And there's quite a few good narrative review articles that I've referenced there that go through them all and summarizes the evidence. But with our local experience, we give it intravenously to our N equals 4 now. We're up to 4 patients. And how it's expressed is the dose of phage is expressed in plaque-forming units, PFUs. And this is the dose that we've adapted really from the previous studies that's been published in Nature for microbacterial infections and John Idell's work. But really, the hypothesis of this dose is that it achieves a target 10 to 100 phages per bacterium, and it's under the FDA threshold of 5 endotoxin units per kg per dose. And it's used as adjunctive therapy with antibiotics. And this poses a lot of research questions that is really yet to be conclusively answered, whether or not there's synergy, antagonism, whether or not it lowers the MSC of antibiotics or decreases the rate of antimicrobial resistance of the antibiotic or the phage. And there is an absence of clinical trial data, but watch this space, because there's a lot of people trying to fill, a lot of clever researchers trying to fill this gap. So are phages safe? So that's a common question I get. And really, when we think about using viruses for therapeutic options, the initial visceral response is that if you look at all the storylines of post-apocalyptic zombie movies, they all start with viruses being novel treatment and then causing a zombie apocalypse. But fortunately, I can confidently say that Westmead Children's Hospital isn't patient 0 site 0 for our zombie apocalypse. So phages are safe. There are a lot of post year 2000 descriptions of its use in multiple routes: oral, local, inhaled, IV. Within our patients, we've described mild adverse reactions that are very transient and resolve quickly within a matter of days to 2 weeks. What I did want to alert is that there are three Australian publications of its use by, one of them being R&A, Sue Maddox, who works at Westmead Adults, and Tim Gilby. So we do have some Australian representation here in the phage space. So in the interest of time, I'm just going to skip through these, but basically there's 3 modern clinical trials looking at safety of its use. I'm skipping these 2 because they're all topical use showing it's safe. But the most important trial that showed safety is Alex and John Ardell's work, which was really giving it intravenously for 14 days of 90 days follow-up as a prospective single-arm study, and showed no adverse effects attributed to phage treatment. So taken all together, phage treatment is safe, but despite this, there should always be a detailed plan with newer or resurgence in older treatment. And this is described really in some of the protocols that many of the sites around Australia are enrolled in for this Phage study. A common question I get is, what work does a pharmacist need to do with phages? And pharmacists there's a lot of work done behind closed doors with phages that gets unrecognized. And I've broken it up, or I've described it in this table, I've broken it up into 2 columns when you got the genetically modified and the non-genetically modified one. The 2 key differences there is that the non-genetically modified ones can be made up on the wards, but the GMO ones, they need to be prepared in an OGTR-approved BSc cabinet by a pharmacist. And this is me taking selfies of myself in one of the ones we have here at Westmead Children's Hospital. Another thing that's quite unique is the education and empowerment of medical staff, nursing and pharmacy, because there is a level of uncertainty out there, and it's important to really empower them to develop guidelines around its administration, storage, and spill kits, and the appropriate approval, because regulation of phages is a current challenge at the moment that is still being workshopped out by a lot of the key researchers in this space. But what's quite specific for phage that pharmacists should be aware of is that you need to get a BICON permit, which is Australian Biosecurity Import Conditions Permit. And you log online, it basically gives you a 3-year permit, but it needs to be specific to the phage that you have imported in to your country. So that's something that the pharmacists in this room should be familiar about when we are procuring these phages. We also assist in quality assurance, the logistics with couriering, cold chain, when it gets to the pointy end of charting it, how the doctors chart it. We need to be involved in that from a HPPL, EMEDS standpoint, because this is how they're described. They get these weird and wonderful names. And because antimicrobials is given in combination of phages, there is quite a lot of pharmacy clinical review involved. For example, for our mycobacterial abscessus patient previously, this patient was on ticacycline, ceftaz-avi, linezolid on top of phages. We needed to assess its applicability for hospital and the home use. So there's all these pharmacy clinical services that are involved in these quite complex patients on phage treatment. So all up, it can take up to 5 hours per week for one phage patient. So that's the work required for us as pharmacists. So take-home messages. So why do you need to know about phages? Because the drugs don't work. AMR is an issue. It's a current issue now, and we're facing these patients at the bedside. Phages are not new. It's a resurgence of older treatment, but the literature has its limitations. So we need to appreciate the gaps, but also watch this space, because there's a lot of Australian researchers filling these gaps up. It is described to be safe to use, but also it's important to be vigilant in measuring its adverse effects and monitoring its adverse effects. And lastly, pharmacists are key stakeholders in phage treatment. It's advanced therapeutic. It's not prescribing Keflex. It requires a lot of background work and work behind closed doors. So it's 2022, and the most effective way of communicating is via meme form. And this is apparently the most popular meme to this date. And back from 1930 to 2022, this is what it was like. But now, post 2022, we're now looking back at phages for treatment. So I'm going to leave this meme up, and then I will pass it on to our chair.
Fabulous. Thank you so much to Joni, Kyall and Tony, and I think you'll all agree those were just fantastic presentations. And I noticed that we have a couple of questions, so I'd really like to take this opportunity to introduce Dr. Laura Fawcett, who's a respiratory consultant and our Advanced Therapeutics Medical Lead at Sydney Children's Hospital, who's going to facilitate and take us through the Q&As. Thanks, Laura.
Thanks, Paula. So the first question we've got up is targeting Joni, I believe, asking about Zolgensma and asking if it is specific to an SMA type.
This is specific. There's a few different types of SMA, and I'm not actually sure which ones it fully covers. I'd probably need to go back and double check because there are a few different variants. Because some of the ones are quite lethal, where the child doesn't make it, untreated past 6 months, where there's a few quite mild ones that'll go into adulthood. But at the moment, what it is covered for, it's only for very young children. So any patients who have SMA that are kind of now children, adults, none of that is currently covered. So any of those really milder forms, and there's still probably going to be some ongoing research with different therapies for SMA kind of in the older population. But yeah.
Thanks, Joni. There's some other therapies that are available for those other patient groups. Is that right?
Yeah, and I think even for some of kind of the older patients, that they can access some things like Spinraza, and some of the adult patients that they're still actually fighting to get some of that stuff on the PBS. So kind of depending how severe or mild the variant actually is, because there has been some adults that are patients that have made it as far as adulthood with some symptoms, and the government is actually refusing to even give things like Spinraza on the PBS, and they're still actually fighting for that. So there still are some gaps in the evidence base in terms of what treatments are actually going to be useful for what patient types.
Thanks, Joni. Got some questions in here that look to be targeted to you, Kyall, about CAR T therapy. So people are interested in knowing how many patients have come through SCH and being treated, and how often tocilizumab is needing to be used for CRS in the patient groups.
Thanks for that question. Yeah, that's great. I do have some of that data. So we have had 9 patients treated at SCH with Kymriah, and that's actually been 11 infusions. So we have had a patient who unfortunately had a loss of B-cell aplasia and relapse after the CAR, and so we've given a re-infusion of their CAR T cells. So yeah, that's how many patients, and we're predicting around 7 to 8 patients a year is probably the projection, and that may increase in the coming years post-COVID.
So as on that note, has COVID impacted the ability to deliver the therapy?
I think it's made it a little bit more difficult, especially with some patients having to come from Perth, which has been sort of like Fort Knox, and that's made it difficult. But if the patients have needed CAR, we just have managed to facilitate that if required. It just takes a lot more organisation than I guess normally, pre-COVID really. But and the CRS, we have had to use tocilizumab for a number of patients. So I think it's 4 patients received 1 or more doses of tocilizumab for CRS/ICANS.
Thanks, Kyall. Tony, I can see you trying to type an answer, but I'm going to put you on the spot and make you answer it live. You can unmute yourself.
Yeah, so Reva has asked, which diseases are we currently treating phages for? Is it mostly respiratory infections? So the first patient was a bone and joint infection, chronic osteomyelitis with Pseudomonas. The other two patients were of lung sources, and they were both CF patients with Mycobacterial abscessus as the pathogen. The fourth one we are looking to treat is an oncology patient who seems like disseminated mycobacterial infection from what I understand. So that's the range of patients that we have treated locally, but in the literature, it's wide ranging. And John Idell's treated full-blown sepsis, endocarditis, Staph aureus bloodstream infections. So the utility of phages is quite broad. Yeah.
Thanks, Tony.
And then the other question is about naturally occurring. So yeah, this is a good question. Our experience is we have only used engineered ones because it's been customized tailored phages, whereby we send a sputum or a microbiological sample to our source, which is University of Pittsburgh, and they customize the phages for that bug. But if you do look at the whole breadth of literature, there is different types being naturally occurring or engineered.
Thanks, Tony. Joni, I'm going to come back to you and ask you about the training that's required for pharmacists delivering these therapies. Is there specific training that is outside what a pharmacist would expect to get in their training, and is there a particular level of pharmacist that needs to be involved in these therapies?
We have kind of been learning as we go along, to be honest, because we've only been using these therapies for a few years. But what I would say or suggest that anybody who is using it is one, clinical trials training, because a lot of the gene therapies that are coming through, or most of them, are still in clinical trials. In terms of the actual preparation manufacture, it's actually pretty easy once you kind of know what you're doing within a PC2. So you can get a junior pharmacist trained to do the manufacture. You probably need senior pharmacy involvement then when it comes to some of the governance around it. Like I said, they're really expensive therapies. And when it comes to kind of the storage and handling, and developing policies and procedures to be able to use these therapeutics, then you probably do need somebody senior involved. Anything that has been with the finances has all gone through the director of pharmacy as well, because a lot of these are going into the hundreds of thousands. Zolgensma at a point was listed at, I think, 2.3 million US dollars. So kind of any of those decisions need to be made from higher up. So I would say overall, you probably do need one senior pharmacist who knows kind of what they're doing overall, but kind of for a more junior pharmacist can be trained in manufacture, can be trained in biosafety, and can be trained in clinically triaging the patient.
Thanks, Joni. Kyall, I'll come back to you. So there's a couple of questions popped in about, I'm not sure whether you'll be able to cover this, but they want to know the outcome of the ALL patients after CAR T cell therapy in Australia so far. It was a very broad question.
Yeah, I think the data is still being collected, really. I can speak to our experience so far. I think that we've had remission in all the patients that we've treated. And obviously this is only 2 years into our data collection. for these patients. So we've had a good response. Unfortunately, we have had some one patient, two patients lose B-cell aplasia after less than 6 months, which is a poor prognostic factor. So one of those patients is actually coming for a reinfusion this week. But otherwise, our other patients remain in remission, which is great. So, and yeah, that's sort of what I can comment on so far. I think it's probably likely to be similar to that real world data paper that I put in the presentation. So that's probably the best place to be looking for that kind of data. Thanks.
Thanks, Kyall. And then I was just looking, I think you've already answered this one, Tony. You got ahead of me in the Q&A about phages, but you've been naturally occurring and engineered. But would you like to just make a comment about matching phages to treatments and how easy is it to identify the right treatment for a patient?
So I don't know if I'm the right person to answer that question, because from what I see from what Alex and what John do is the assessment of whether or not the organism is appropriate for phage treatment is basically getting the sputum and sending it, or getting the sample, sorry, and sending it to our phage source. But there is, I had a slide earlier before of the phage bank, where for our first patient, John and Amine, I'm not sure exactly what they did, but they sent out a request for a phage for that Pseudomonas, and they got multiple hits back from this large phage directory. And then Amine and John go through the successful hits from that phage bank, and they basically select the most appropriate source of phage, and at the time it was adaptive phages. So that's currently what's available now, this phage directory. But I know that John is putting in a lot of thought and planning and a lot of money in creating an Australian bank of phages. So I think the ultimate plan for phage therapy in Australia is that clinicians all around Australia can send in their microbiological sample to our Australian phage bank, and we get local hits of tailor-made phages, and then yeah, it's all made locally here. That's a GMP phage product that is free of contaminants like bacterial lysates, toxins, and liposaccharides that can cause immune reactions if it's not made to GMP standards. So that's ultimately the future direction of where we see phages in Australia. So it's more of a watch this space type of answer, because it's constantly evolving, and it also is a very competitive research space as well. Yeah.
Fantastic. Thanks, Tony. It's really exciting to kind of hear that answer. So definitely watch this space.
Thank you so much, Laura. And I know that we've come to time, and I just, unfortunately, we have run out of time, but certainly we will provide answers to questions that we didn't have time to answer in this session via our website in the coming days after the webinar. So I just wanted to again extend my sincere thanks to our speakers, to Laura, and certainly to Lani, who's been in the background coordinating today's webinar. So thank you so much, and thank you for all our participants online for joining us today. So as I mentioned, there will be a video of today's webinar, which will be available via our website and the Sydney Children's Hospitals Network YouTube channel. There will also be a short survey at the end when we log off. So please, if you do have a spare moment to fill it out, we'd really appreciate your feedback. It really helps us in subsequent planning for future webinars. webinars. So just lastly, a really huge thank you to Joni, Kyall and Tony for your time. It was a really fantastic webinar, and to our Q&A facilitator, Laura, again, thank you. Really fantastic questions, and apologies we didn't get more time to answer all of them. And I really want to thank all of the staff at the Sydney Children's Hospitals Network who've supported today's presentation. As you would have seen, there's a lot of background work that goes in, so thank you. And please all stay tuned for our next webinar in May, where we get to explore the clinical journey for patients undergoing treatment with gene therapy for inherited retinal disease, which we heard a little bit about in Joni's presentation. So we'll certainly have the opportunity to do a deeper dive on that, and we really look forward to having you join us then. So thank you all so much for joining today.